Welcome to the deep dive. The shoulder is this incredible piece of biological engineering, just the most mobile joint in the human body.
It really is amazing.
Today, we're going to unpack how specialists are using these cutting-edge techniques, arthroscopy and endoscopy, to, understand and fix its many quirks and injuries.
Yeah.
We've got a fantastic, really in-depth textbook as our source, and our goal is basically to pull out the most useful and fascinating insights into how these minimally invasive procedures are actually done.
That's right. And what's remarkable about this field is just the sheer scope of what can now be addressed without those large incisions.
Exactly.
This textbook really lays out everything from, the basic anatomy you need to get your head around to the really advanced surgical solutions for all sorts of shoulder problems like rotator cuff tears, instability.
A whole gamut.
Yeah.
And it's not just about what's possible now. The author's enthusiasm for the future of shoulder surgery is, it's pretty infectious. He genuinely believes the field is advancing so rapidly that this entire book might need a complete overhaul within the next decade.
Wow.
That gives you a real sense of how much innovation is happening, doesn't it?
It certainly does. It's moving fast.
Okay, let's unpack this. We can't really talk about fixing the shoulder without understanding what makes it tick.
Absolutely fundamental.
Let's start with the arthroscopic anatomy, this incredibly mobile glenohumeral joint. That's where your upper arm bone meets your shoulder blade. How does it manage to be so flexible, yet stay stable?
It's a clever combination of what we call passive and active stabilizers. So think of the passive structures as the underlying framework.
Okay.
You've got the glenoid, which is the shallow socket on your shoulder blade, the head of the humerus, the ball of your arm bone fitting into that socket, the labrum.
That cartilage ring?
Exactly, that cartilage ring around the glenoid that deepens the socket. Then there's the joint capsule, the fibrous tissue enclosing the whole joint, and the ligaments, those tough bands connecting bone to bone.
So that's the static support, the framework. Now for the active part, the muscles.
Exactly. These are the dynamic controllers allowing for movement and providing crucial stability. The rotator cuff muscles, supraspinatus, infraspinatus, teres minor, and subscapularis are key players here.
Right.
Along with the long head of the biceps, the deltoid, the big muscle on the outside of your shoulder, and all the muscles that control how your scapula, your shoulder blade, moves. It's this coordinated muscle action that allows you to reach for things, throw a ball, everything in between, all while keeping the joint secure.
Now here's a detail that apparently surprises even some experienced surgeons. Telling the supraspinatus and infraspinatus muscles apart during an arthroscopic procedure. It can be tricky.
It really can be. One helpful landmark is often a subtle contour line that naturally separates the two muscles.
Ah, okay.
Also, if we see cysts or bony spurs, what we call osteophytes, around the greater cuperosity, that's that bony bump on the outside of your upper arm bone, it can suggest long-standing subacromial impingement.
Impingement. That's the narrowing of the space.
Right, a narrowing of the space above the rotator cuff. And this can sometimes give us an indirect clue about potential issues with the underlying rotator cuff muscles themselves.
Okay, so once we have a sense of the anatomy, how do we actually get a look inside a living shoulder?
Yeah.
Radiological investigations are obviously crucial, and it sounds like good old x-rays are still the starting point.
Absolutely. X-rays are fantastic for that initial overview, especially for identifying things like dislocations and fractures. Different views let us see the bones from various angles, which is key for diagnosing specific problems.
Makes sense.
For example, the standard AP, anteroposterior, scapular Y, and axillary views are pretty essential for evaluating acute shoulder dislocations. Then you have specialized views like the West Point and striker notch views. These are particularly helpful for visualizing fractures on the front of the glenoid socket or those Hill-Sachs lesions.
Those little dents on the humeral head from dislocations.
Exactly those, the ones that can happen when the shoulder dislocates forward.
And when we need to really see the soft tissues, the muscles, tendons, ligaments, that's where MRI and MRA come in, right? What's the difference there?
So MRI, magnetic resonance imaging, gives us incredibly detailed pictures of all the soft tissue structures. MRA, or MR arthrogram, takes it a step further.
How so?
By injecting a contrast dye directly into the joint before the MRI scan. This contrast really highlights the outlines of structures like the labrum and ligaments, making tears much easier to spot.
Ah, clever.
For instance, putting the arm in a specific position called ABER, that's abduction and external rotation during an MRA, can significantly improve our ability to detect tears in the anteroinferior labrum, the front and bottom part of that cartilage rim.
I see.
This can help us identify specific types of injuries, like ALPSA lesions.
What are those again?
That's where the torn labrum isn't just torn, but it also gets pushed and kind of rolled onto the neck of the scapula.
Yeah.
MRI also helps see ruptures of the inferior glenohumeral ligament, or IGHL, a key stabilizer.
Got it. Now, CT arthrography is another imaging technique mentioned. Where does that fit in?
CT arthrography, which combines a CT scan with that contrast injection into the joint, is really good for seeing the bony architecture in great detail.
Okay, so more for bone.
Primarily, yes. It's particularly useful for assessing the amount of bone loss in the glenoid socket, which is crucial information in cases of recurrent instability. However, it's generally not as sensitive as a direct MRA for picking up small, non-displaced tears in the labrum.
Now, interpreting these MRI scans isn't always black and white, is it? I read there are anatomical variations that can sometimes look like tears.
That's a really important point, especially in the anterosuperior part of the labrum, roughly the top and front of the socket. There are a few common anatomical variations that can sometimes be mistaken for SLAPs.
SLAP tears. Superior labrum tears.
Right, tears of the superior labrum. These variations include the Buford complex.
Okay, Buford complex.
That's where a portion of the anterosuperior labrum is missing, and the middle glenohumeral ligament is thickened and sort of cord-like. We also see things like a sublabral sulcus, which is a small groove beneath the labrum, and a sublabral foramen, a small hole in the labrum.
That Buford complex sounds interesting. What's the key thing for surgeons and maybe patients to know about it?
Well, the key thing is recognizing it as a normal variation, so you don't mistakenly diagnose a labral tear that isn't actually there.
Right. Avoid unnecessary treatment.
Exactly. Interestingly, though, some recent research suggests that this specific anatomical setup, the Buford complex, might actually make individuals a bit more prone to developing SLAP lesions later on, perhaps due to altered biomechanics in the shoulder.
Okay. Beyond the soft tissues, the shape of the acromion, that bony prominence on the top of your shoulder blade, that can also play a role in shoulder problems, can't it?
Absolutely. We classify the shape of the acromion into 3 types based on what it looks like from underneath on a specific X-ray view, the oblique Y view.
3 types.
Yep. Type 1 is essentially flat, Type 2 has a gentle curve, and Type 3 is also curved, but with a hook-like projection pointing downward.
Ah, the hooked one.
Right. It's this Type 3 acromion that has the strongest link to subacromial impingement, that compression of the rotator cuff tendons, and consequently rotator cuff tears. The hook shape basically narrows the space where the tendons have to glide.
And there's also the acromial index, a measurement we can take on X-rays. What does that tell us?
The acromial index, or AI, is a ratio. It compares 2 distances measured on a frontal X-ray of the shoulder.
Okay.
It's the distance from the edge of the glenoid socket to the outer edge of the acromion, divided by the distance from the glenoid to the outer edge of the greater tuberosity.
So a bigger number means the acromion sticks out more.
Exactly. A higher AI value means the acromion extends further laterally, or sideways. Studies have shown that people with a higher acromial index are more likely to experience subacromial impingement and have rotator cuff problems.
Interesting correlation.
Yeah, for example, people who don't have any shoulder issues tend to have a lower AI, while those with significant rotator cuff tears often have a higher AI. It just gives us another piece of the puzzle when evaluating shoulder pain.
Let's switch gears a bit and talk about the biceps tendon. It's not just about flexing your arm. It plays a role in shoulder stability too, doesn't it?
It absolutely does. The long head of the biceps tendon, or LHBT, is held in its groove at the front of the upper arm bone by a really important structure called the biceps pulley, sometimes also called the biceps sling.
The pulley.
Yeah, this pulley is a complex of ligaments and tendon fibers. It's primarily made up of the superior glenohumeral ligament, the coracohumeral ligament, and also fibers from the subscapularis tendon as it wraps around the front of the shoulder.
Okay.
Interestingly, the transverse humeral ligament, which you might have heard of as holding the biceps tendon in place, is now understood to be largely composed of fibers coming from the subscapularis and supraspinatus tendon.
Ah, so it's more connected than we thought.
Right. And because this whole biceps pulley sits within the rotator interval, that gap between the supraspinatus and subscapularis tendons injuries in this area often involve the pulley as well.
How do you spot those pulley injuries?
Ultrasound can be a really useful tool here. It can actually let us see injuries to the ligaments that make up the biceps pulley, like the SGHL and CHL, and detect if the biceps tendon is slipping out of its normal position, which we call subluxation.
Another common and often frustrating shoulder issue is adhesive capsulitis or frozen shoulder. How can imaging help with that diagnosis?
Well, the diagnosis of adhesive capsulitis is mainly based on a patient's symptoms and a physical exam showing that restricted movement.
Right, the classic stiffness.
Exactly. But MRI can be helpful as an additional tool, primarily to rule out other conditions that might be causing similar pain and stiffness.
So ruling things out.
Mostly. In some cases of adhesive capsulitis, though, an MRI might show a thickening of the joint capsule itself and sometimes even a small amount of fluid within the joint. But it's not always definitive just from the scan.
Finally, for this section, let's touch on the acromioclavicular joint, the AC joint, where your collarbone meets the acromion. Osteoarthritis is quite common there, isn't it?
It is. Acromioclavicular joint osteoarthritis, or ACJOA, can develop as a result of a direct injury to the AC joint, like a fall onto the shoulder. It's also frequently seen in people who have subacromial impingement.
Okay.
On imaging, we might see signs of wear and tear in the joint, like the cartilage thinning, bone spurs forming those osteophytes again, and sometimes even small cysts in the bone just below the cartilage.
And distinguishing old injuries from arthritis.
Yeah, early signs of ACJ degeneration can sometimes be hard to tell apart from old, minor sprains of the AC joint, as both can show some thickening of the joint capsule. If we also see involvement of the corticoclavicular ligaments, the ones holding the clavicle down, that often suggests a more significant past injury to the AC joint.
Okay, we've covered a lot of ground on anatomy and diagnosis. Let's move into treatment. Arthroscopic surgery relies heavily on the use of cannulas. What are they and why are they so important?
Okay, so think of cannulas as little access tunnels into the shoulder joint. They're hollow tubes that we insert through small incisions.
Got it. Tunnels.
And they're absolutely essential for making arthroscopic surgery efficient. They allow us to easily swap different surgical instruments in and out as needed without having to make multiple large incisions or constantly repuncture the skin.
Makes sense.
They're also crucial for managing sutures during the procedure, preventing them from getting tangled or catching on other tissues.
What kinds are there?
Cannulas come in various sizes, lengths, and materials. You have soft silicone cannulas, which are less bulky and can even help with gently retracting tissues inside the joint, but you have to be careful with sharp instruments around them.
Right.
Then there are hard cannulas, more resistant to accidental puncture, but sometimes less maneuverable, especially if you're using several at once.
Any downsides?
Well, one important thing to watch out for is fluid extravasation. If a cannula accidentally slips out of the joint during surgery, the fluid we use to inflate the joint can leak out into the surrounding soft tissues.
Ah, okay. Needs careful management. Now, arthroscopic fixation of bony Bankart lesions, that's when a piece of bone breaks off the front of the glenoid during a shoulder dislocation. That seems like a key area where these techniques have really made a difference.
They absolutely have. For smaller bony Bankart lesions, what we sometimes call Bigliani type I or II, where the bone fragment is still in relatively good shape and hasn't shifted too much, arthroscopic reduction, basically putting the bone back in place, and internal fixation holding it there with anchors and sutures is often the preferred approach. The goal is to restore that smooth, continuous surface of the glenoid socket.
But there's a limit. Right, if the bone loss is too big.
Exactly. If the glenoid defect is larger than about 20 to 25% of the socket surface area, that's generally considered a critical size.
Okay.
In these cases, arthroscopic repair alone might not be enough to prevent future dislocations, and other procedures like the Latarjet or bone grafting might be necessary to rebuild the socket.
And techniques for fixing those fragments arthroscopically.
Surgeons often use specific techniques, like the double pulley technique, to get a really secure hold on those bony fragments during the arthroscopic repair.
What about the success rates of these arthroscopic Bankart repairs? Does it matter if the shoulder has been dislocating for a while versus, say, a first-time dislocation?
That's a good question. The research suggests that arthroscopic Bankart repairs tend to have better outcomes when performed after an acute or first-time dislocation compared to chronic recurrent instability.
Why is that?
Well, studies have shown that many patients with acute glenoid rim fractures can regain stability and get back to their previous activities after a single row of anchors is used to fix the bone and labrum. But the results for chronic cases treated with the same single row technique have sometimes been less predictable. It's possible the bone and ligaments can change over time with repeated dislocations, making them harder to repair effectively.
But it's not always clear-cut.
No, interestingly, some studies have reported good success, even in chronic cases where the bone fragments are still well preserved. And more recently, techniques using 2 rows of anchors, so-called double row repair, have shown promising results for both acute and chronic instability.
Double row. More anchors, better fixation.
Potentially, yes. It creates a wider area of contact. Patients report good satisfaction and improvements in how the shoulder feels and functions, but ultimately, a really important factor in the success of any Bankart repair seems to be making sure the reconstructed glenoid socket is at least 80% of its original size.
That makes sense, restoring the anatomy. Now, for shoulder instability in general, surgery isn't always the first thing doctors recommend, is it?
That's correct. Non-operative treatment is often the first step. This usually involves wearing a sling for a few weeks to let the initial injury calm down, followed by a structured rehabilitation program.
Physical therapy.
Exactly. The rehab focuses on strengthening the muscles around the shoulder, especially the rotator cuff, and gradually restoring the full range of motion.
But when is surgery indicated?
Surgery might be recommended if the patient continues to experience symptoms like feeling the shoulder wants to slip out of place, that's a positive apprehension sign, or if a doctor can physically put the shoulder back in place during an exam, which is a positive relocation sign.
Okay.
Also, if certain exam maneuvers like the augmentation test or lag sign are positive, or simply if conservative treatment doesn't provide enough relief and the shoulder continues to be unstable and really limits their function.
Right. Let's move on to some specific shoulder conditions and their surgical management. The Letarget procedure is a well-known option for people with shoulder instability and significant bone loss. Can that be done arthroscopically?
Yes, it can. The traditional Letarget procedure, which involves taking a piece of bone called the coracoid process from the front of the shoulder blade and transferring it to the front of the glenoid to act as a bony block.
Right, the bone block.
That's been performed as an open surgery for a long time and has a good track record for stabilizing the shoulder. But since about 2003, surgeons have also been performing the Letarget procedure arthroscopically using smaller incisions.
What are the trade-offs?
Well, the arthroscopic approach can offer potential benefits like less pain and maybe quicker recovery. But both the open and arthroscopic Letarget procedures carry some risks.
Such as?
One potential complication is a fracture of the transferred coracoid bone itself, which can happen in the first few months after surgery. There's also a risk of nerve injury because of the delicate dissection involved near important nerves.
When the glenoid bone loss is quite substantial, are there other surgical options besides the Letarget?
Yes, for more significant glenoid bone loss, surgeons sometimes use what we call extra anatomic procedures. These include the Letarget Bristow procedure, which is a variation of the Letarget, or using a separate piece of bone, often from the iliac crest, your hip bone.
A graft from the hip.
Right, using that as a bone block that's then fixed to the glenoid, usually with screws.
But those have potential issues too.
They can. Complications like the bone not healing properly, non-union, the bone graft being reabsorbed by the body over time, or problems with the screws or other hardware used to hold the bone in place can occur.
So, alternatives?
Well, the arthroscopic J-bone grafting technique offers another approach. This involves taking a bone graft from the iliac crest, shaping it carefully to fit the glenoid defect, and then securing it arthroscopically.
What's the advantage there?
A key advantage is that it's arguably more anatomical, aiming to restore the natural shape of the glenoid. Plus, it doesn't leave behind permanent metal implants like screws.
Okay. There's also a technique mentioned called arthroscopic bone block with subscapularis augmentation, or ASA. What's that all about?
The ASA procedure is a more complex arthroscopic technique. It's designed for cases of severe glenoid bone loss combined with a deficient capsulolabral complex, meaning both the cartilage rim and the surrounding ligaments are significantly damaged.
So a double whammy.
Pretty much. It involves creating tunnels in the glenoid bone to precisely position and secure a bone block graft using strong button-like anchors.
And the subscapularis part.
Importantly, it also includes augmenting or reinforcing the subscapularis tendon, that key stabilizer on the front of the shoulder, often using a strong suture tape anchor.
So it's bone block plus tendon reinforcement.
Exactly. This combined approach has shown promise as a feasible and safe alternative to the traditional Latarjet procedure in these more challenging instability cases.
In situations where the bone loss isn't quite critical, are there other types of grafts that might be considered, like, not from the hip?
Yes, for glenohumeral instability with a smaller degree of bone loss, or in cases where a Hill-Sachs lesion, that dent on the humeral head, is off track, meaning it's likely to engage with the glenoid rim during movement, an arthroscopic distal clavicle osteochondral autograft transfer might be an option.
Taking bone from the collarbone.
Right. This involves taking a small piece of bone and its overlying cartilage from the end of the clavicle and transplanting it to the glenoid defect.
When wouldn't you use that?
Well, this technique is generally not recommended for patients who have very loose joints overall, what we call global hyperlaxity, or if they have significant bone loss on the humeral head itself, or if they've had a previous resection of the end of the clavicle.
Okay. What happens when a Latarjet procedure, unfortunately, doesn't achieve the desired stability? Is revision possible?
Revision surgery after a failed Latarjet procedure can be quite complex, as you can imagine. Surgeons sometimes use a specific posterior portal, an entry point at the back of the shoulder called the Halifax portal.
A specific portal?
Yeah, this portal can provide better access and visualization of the surgical area during these tricky revision procedures, allowing for a more thorough assessment and repair.
Now, Hill-Sachs lesions, those indentations on the humeral head from dislocations, can also contribute to ongoing instability. The remplissage procedure is designed to address those. How does it work?
The remplissage procedure aims to prevent a Hill-Sachs lesion from catching or engaging on the edge of the glenoid socket during shoulder movement, which can cause further instability or pain.
So how do you stop it catching?
It involves essentially filling in the Hill-Sachs defect with soft tissue, typically by using a portion of the infraspinatus tendon, one of the rotator cuff muscles, and anchoring it right into the bony defect on the humerus.
Filling the dent.
Basically, yes. This procedure is often considered in cases where there's an engaging Hill-Sachs lesion, but less than 25% of glenoid bone loss. It's often done alongside a Bankart repair.
HEGL lesions. That's when the inferior glenohumeral ligament tears away from its attachment on the humerus. They also require specific attention, right?
Yes, definitely. Arthroscopic repair of HAGL lesions, where the ligament is reattached to the humerus using anchors, is certainly possible and often effective.
Is the recovery different depending on where the tear is?
The postoperative care can differ slightly. For anterior-inferior tears, on the front and bottom, immobilization in a standard sling is typical. For reverse HAGL tears on the backside, surgeons might use an external rotation brace or an abduction pillow to protect the repair, as these positions put less stress on the repaired posterior ligament.
Okay. Posterior shoulder instability, while less common than anterior instability, still poses challenges for diagnosis and treatment.
It does. Arthroscopic assessment is really valuable in evaluating posterior shoulder instability to identify if there are any associated bone or soft tissue injuries, like a reverse Bankart lesion or posterior labral tear.
Is surgery always the answer?
No. Surgery is generally not recommended for patients who can voluntarily dislocate their shoulder or those who aren't likely to be cooperative or able to actively participate in the extensive rehabilitation process required afterwards.
Right.
In some chronic cases where pain is minimal and function is still reasonably good despite some laxity, non-operative management might actually be the preferred approach.
Multidirectional instability, or MDI, is when the shoulder feels loose in multiple directions. How is that managed arthroscopically?
MDI is a complex condition. It can be caused by a combination of factors, including naturally loose joints, congenital hyperlaxity.
Born with loose joints?
Sometimes, yes. Or it can be due to repeated minor injuries, like microtrauma, imbalances in the muscles around the shoulder, and certain anatomical predispositions.
What do surgeons see arthroscopically?
A key finding is often laxity in the coracohumeral ligament and an overly loose or redundant joint capsule, especially in the front and bottom parts of the joint.
So how do you fix that looseness?
Arthroscopic capsular plication, or ACP, is a surgical technique used to address this. It involves taking tucks or pleats in the joint capsule to effectively tighten it up and reduce the excessive laxity. These pleats are then secured with sutures or anchors.
How does that compare to older open surgeries?
Compared to older, open surgical procedures called capsular shifts, ACP offers advantages like smaller incisions, less scarring, often less pain after surgery, avoiding the need to detach and reattach the subscapularis tendon, and potentially a quicker return to sports.
And the results?
Studies have reported quite promising success rates with ACP in appropriately selected patients who have true MDI.
Okay, let's talk rotator cuff tears. A very common source of shoulder pain and weakness. What are some of the newer developments in arthroscopic repair techniques?
Arthroscopic rotator cuff repair techniques have certainly come a long way. One promising advancement is the linked double row suture bridge, or LDRSB, repair.
That sounds complex, LDRSB.
It does, but the idea is to improve healing. Studies have suggested that this technique can lead to higher rates of tendon healing and potentially fewer repeat tears compared to traditional single row or even standard double row repairs.
How does it work?
The idea behind the suture bridge is to create a wider footprint of tendon-to-bone contact and provide more even pressure across the repair site, which theoretically promotes better healing conditions.
And knotless anchors.
Yes, we're also seeing an increasing use of knotless anchors. These simplify the process of tying sutures and securing the tendon to the bone arthroscopically. This can potentially reduce the risk of complications related to knots, like irritation or suture breakage, and maybe speed up the surgery slightly.
Interesting. Now, subcoracoid impingement is something many people haven't heard of, but it can be a source of pain in the front of the shoulder. How is it diagnosed and treated arthroscopically?
Right. Subcoracoid impingement happens when the space between the coracoid process, that little hook-like bone at the front of your shoulder blade, and the humeral head becomes too narrow. This often causes friction on the subscapularis tendon, which runs between them.
What causes it?
It can be caused by repetitive movements or certain anatomical variations where the coracoid is maybe a bit larger or angled differently.
And diagnosis?
Imaging, especially CT scans that can precisely measure the distance between the coracoid and humerus and calculate various indices, can be very helpful in making the diagnosis.
And the arthroscopic fix?
Arthroscopic coracoplasty. This involves using a small, high-speed burr to carefully shave away a small amount of bone from the tip or underside of the coracoid process to widen that space and effectively relieve the impingement.
How do you find the coracoid during surgery?
It's crucial to identify it accurately. The technique can vary slightly depending on whether the subscapularis tendon underneath it is intact or has retracted due to a tear. A helpful landmark in cases where the subscapularis has retracted is the comma sign, which includes the coracohumeral ligament attaching near there.
Okay. The subscapularis tendon itself, one of the rotator cuff muscles, can also be torn. Is that being recognized more now with arthroscopic surgery?
Absolutely. The subscapularis is a really important rotator cuff muscle. It plays a crucial role in shoulder movement and stability, particularly internal rotation turning your arm inwards.
And it used to be missed.
Historically, yes. Tears of the subscapularis, especially partial tears on the joint side, were often missed with traditional open surgical approaches. It even got called the forgotten tendon.
Wow.
But the ability to directly visualize the tendon with shoulder arthroscopy has significantly increased our recognition and diagnosis of these tears.
How is it repaired arthroscopically?
Arthroscopic repair typically involves establishing standard entry portals around the shoulder, then performing an anterior release to carefully free up the tendon from any scar tissue before reattaching it to its insertion point on the lesser tuberosity using suture anchors.
Any specific risks?
Surgeons have to be particularly careful during that anterior release to avoid any injury to the nearby axillary nerve, which runs quite close.
Sadly, not all rotator cuff tears are repairable. What are the options when a tear is just too big or retracted, deemed irreparable?
That's a tough situation. For massive rotator cuff tears that can't be repaired directly back to the bone, there are several surgical and non-surgical management options.
Like what?
A subacromial balloon spacer can be inserted arthroscopically. This is like a temporary inflatable cushion placed between the humeral head and the acromion.
A cushion. How does that help?
It helps to keep the humeral head centered in the socket, reducing pain and improving function, especially in older patients who still have a good range of motion and a strong deltoid muscle. But it's not suitable for everyone, and it's not a permanent fix.
Other options.
The long head of the biceps tendon can also be repurposed. It can be used as a vascularized graft in a technique called the biceps patch for superior capsule reconstruction, where the top part of the shoulder joint capsule is reinforced or rebuilt.
Using your own tissue.
Exactly. Another well-established option is a latissimus dorsi tendon transfer.
moving a back muscle.
Right. The latissimus dorsi muscle from your back is rerouted to the shoulder to help with external rotation and abduction, typically in younger, more active patients with tears on the back and top of the rotator cuff, provided their subscapularis tendon is intact.
And newer transfers.
More recently, transferring the lower trapezius tendon, often using a donated Achilles tendon as a bridge graft, has been explored as another alternative. This might offer a better line of pull for certain types of irreparable tears.
Lots of ingenuity there. Let's talk about calcific tendonitis, where calcium deposits form in the rotator cuff tendons. That can be incredibly painful, right?
Oh, extremely painful sometimes. The initial treatment for calcific tendonitis is usually non-surgical rest, pain medication, physical therapy, sometimes injections like cortisone, or even procedures to try and break up the calcium with needles.
But if that fails?
If these conservative measures don't provide relief, arthroscopic removal of the calcium deposits can be a very effective option. The surgeon goes in with the scope, finds the deposit, and essentially scrapes or sucks it out.
Are there times when arthroscopy isn't suitable?
Yes, there are a few situations. For example, if the calcium deposit is already in the process of being naturally resorbed or absorbed by the body, surgery might not be needed. Or if multiple tendons are involved, or if the patient also has significant arthritis, frozen shoulder, or has had previous shoulder surgery, it might complicate things.
But generally effective.
In appropriately selected cases, yes. Arthroscopic removal of calcium has reported high success rates in reducing pain and improving function.
SLAP tears, injuries to the superior labrum where the biceps tendon attaches, seem common, especially in athletes who do a lot of overhead activities.
They are. SLAP tears, standing for superior labrum anterior to posterior, involve a tear in the top part of the labrum, often affecting the anchor point of the long head of the biceps tendon. They're frequently caused by repetitive overhead motions, like throwing or swimming, or by sudden injuries like falls onto an outstretched arm or a direct blow to the shoulder.
Diagnosis tricky.
Diagnosing SLA tears can be challenging based on physical examination alone, as the symptoms can overlap with other shoulder problems. So imaging like MRI or MRA is often helpful.
And treatment.
Arthroscopic repair is the main treatment approach for significant symptomatic SLAP tears, especially in younger, active individuals. SLAP lesions are classified into several types based on the pattern of the tear.
Like types 3 and 4.
Right, those are examples. Type 3 involves a bucket handle tear of the superior labrum itself, where the torn piece hangs down, the biceps anchor is intact. Type 4 also has a bucket handle tear, but this one extends into the biceps tendon anchor.
Any specific tests during an exam?
There are several specific clinical tests surgeons use, like the resisted supination external rotation test and the clunk test, that can raise suspicion for a SLAP tear, but none are perfectly accurate on their own.
Okay. Biceps tenodesis, a procedure to surgically fix the long head of the biceps tendon in a new location, is another common surgery. When is that typically done?
Biceps tenodesis is indicated for various reasons. One common reason is pain that seems to be coming primarily from the biceps tendon itself, often called biceps tendonitis. It's also often performed when there's a significant tear in the biceps tendon, or as part of the treatment for certain types of SLAP tears, particularly those where the biceps anchor is unstable, or the tear extends into the tendon, or even sometimes in older patients instead of repairing the SLAP tear. It's also used if a previous SLAP repair has failed.
Any reason not to do it?
There aren't many absolute contraindications, but surgeons might be more cautious in patients with significant other medical problems, or perhaps in older individuals with very low functional demands where the symptoms aren't too bothersome.
What's the preferred technique?
Techniques vary, but one preferred technique mentioned in the source is an arthroscopic intra-articular tenodesis. Here, the tendon is cut inside the joint and then reattached to the humerus right at the edge of the joint cartilage.
Other ways?
Yes, there are also endoscopic-assisted techniques. These involve making a small incision lower down, often in the armpit area or just below the pec muscle, and using an endoscope to help visualize and secure the tendon to the bone in the subpectoral space. Sometimes a special retractor called a homon is used to help with exposure down there.
Got it. Frozen shoulder, or adhesive capsulitis, can be incredibly painful and limit movement significantly. When might surgery be recommended for that?
Patients with frozen shoulder experience this really painful and progressive restriction in both their active and passive range of motion in the shoulder. It can be debilitating.
How is it usually treated first?
Initially, treatment is usually conservative. That means pain medication, maybe anti-inflammatories, intensive physical therapy focused on stretching, and sometimes cortisone injections into the joint.
But if that doesn't work,
If these non-surgical treatments fail to restore adequate range of motion and relieve pain after a reasonable period, often several months, then arthroscopic pancapsular release is often recommended.
pancapsular release.
Yes, this involves surgically releasing the tightened and thickened joint capsule from the inside of the joint using arthroscopic instruments, essentially cutting the tight tissue all around the joint, hence pancapsular.
Does it fully restore motion?
It can significantly improve the range of motion, often dramatically, but it's important for patients to understand that regaining the absolute full range of motion they had before the frozen shoulder, making it perfectly comparable to their other arm, can sometimes still be a challenge even after successful surgery and rehab.
As we get older, osteoarthritis of the glenohumeral joint, that wear and tear in the main shoulder joint, becomes more common. How is it managed in the earlier stages before replacement?
Glenohumeral osteoarthritis, or GHOA, is a degenerative condition, and yes, unfortunately, it becomes more prevalent with age. In the earlier stages, before the arthritis is too severe and causing bone-on-bone pain, surgeons might consider conservative surgical management. This primarily involves arthroscopy to go in and essentially clean up the joint.
What does cleaning up involve?
It can include removing loose fragments of cartilage, smoothing out rough surfaces on the cartilage or bone spurs, maybe releasing a tight capsule, and addressing any associated soft tissue issues like biceps tendon problems or small rotator cuff tears.
The goal?
The goal is primarily to relieve pain and improve function, maybe delaying the need for a joint replacement. But it's important to realize it's not a long-term fix for the underlying arthritis itself. It's more palliative.
Flail shoulder is a very debilitating condition where the arm is essentially paralyzed. Can arthroscopy play any role in helping these patients?
Flail shoulder often results from severe nerve injuries, like brachial plexus injuries or muscle paralysis, leading to a significant loss of the ability to actively move the arm. It just hangs there.
So what can be done?
In certain cases, where the goal is mainly to stabilize the shoulder joint to allow for better use of the hand, especially for tasks at waist level, a procedure called glenohumeral arthrodesis might be considered.
Arthrodesis, fusing the joint.
Exactly, surgically fusing the humeral head to the glenoid socket. Arthroscopic-assisted techniques can be used here to help prepare the joint surfaces for fusion, removing any remaining cartilage, and also to help guide the placement of the wires or screws that hold the bones together rigidly while they heal into one solid piece.
Sometimes, loose fragments of cartilage or bone can float around inside the shoulder joint, causing pain and mechanical symptoms like catching or locking. How are those addressed?
Arthroscopic removal of these loose bodies is an excellent and often the preferred alternative to traditional open surgery.
Why is better?
It allows the surgeon to thoroughly visualize the entire inside of the joint, find all the fragments, even ones hiding in corners, and precisely remove them with minimal damage to the surrounding healthy tissues. Smaller incisions, quicker recovery usually.
Sadly, infections can sometimes occur in the shoulder joint. How are those managed, particularly using arthroscopic techniques?
Septic arthritis of the shoulder, an infection within the joint, is relatively rare but has seen perhaps a slight increase in incidence following injections around the shoulder.
And the treatment?
The preferred treatment approach is usually prompt arthroscopic debridement and irrigation.
Washing it out.
Essentially, yes. It allows for a thorough cleaning and flushing out of the infected joint fluid and any pus or debris. And at the same time, the surgeon can visualize and potentially address any other associated problems, like rotator cuff tears that might be present or contributing.
Even bone cysts in the proximal humerus, the upper part of the arm bone, can be treated using minimally invasive techniques now. How does that work?
Yes, endoscopic curettage is a technique used to treat certain benign bone cysts in the proximal humerus.
Endoscopic, like arthroscopic, but inside the bone.
Kind of. It involves making small incisions to create portals directly into the bone cyst, then using specialized instruments under endoscopic camera guidance to scrape out the lining of the cyst. The goal is to be less invasive than traditional open surgery, where you might have to make a larger window in the bone, potentially leading to faster healing and maybe a higher success rate in resolving the cyst.
A vascular necrosis of the humeral head, where the blood supply to the top of the arm bone is disrupted, is a serious condition. Can arthroscopy help there too?
Arthroscopic-assisted cord decompression and fibular strut grafting is a technique used to try and treat humeral head avascular necrosis, particularly in its earlier stages, before the head collapses.
Core decompression.
That involves drilling small channels into the affected area of the humeral head to relieve pressure and hopefully stimulate improved blood flow or healing.
And the fibula graft.
This is often supplemented by inserting small structural bone grafts, often taken from the fibula bone in the lower leg, into those channels. These grafts provide mechanical support and aim to prevent the humeral head from collapsing. The arthroscopic assistance allows for more precise placement of these channels and grafts with smaller incisions compared to open methods.
What about patients who have already had a shoulder replacement and are now experiencing new problems? Can arthroscopy still be a useful tool for them?
Yes, absolutely. Shoulder arthroscopy can definitely be valuable even after a patient has undergone shoulder arthroplasty or joint replacement.
What kind of problems?
It can be used to diagnose and sometimes treat various complications that can arise after replacement. Things like infection around the prosthetic joint, instability where the replacement feels loose or dislocates, impingement issues where tissues are getting pinched, new rotator cuff tears that can still occur, and even loosening of the components of the artificial joint.
Is it harder to do?
Performing arthroscopy in a shoulder that has already had a replacement is definitely technically more challenging. The anatomy is altered, you have the implants in the way, and scar tissue can make visualization difficult. So it really requires a surgeon with significant experience in this specific area. Often, a posterior portal, an entry point from the back of the shoulder, is preferred in these cases to try and avoid the implants at the front.
Okay. Dislocations of the acromioclavicular joint, the AC joint, where your collarbone separates from your shoulder blade, are common injuries, especially in sports. How are those treated arthroscopically?
Arthroscopic-assisted reduction and fixation techniques are increasingly used to treat the more severe ACJ dislocations, the ones where the clavicle is significantly elevated.
How is it fixed?
These techniques often involve using strong sutures or tapes, like the commercially available tightrope and fiber tape systems, passed around the coracoid process and through or around the clavicle to pull the clavicle back down into its correct position relative to the acromion, and then secure it there while the ligaments heal.
Does it always stay reduced?
While these methods aim to restore the normal alignment, some degree of loss of the initial reduction can sometimes occur over time as things settle or stretch slightly. Interestingly, there's some evidence emerging to suggest that slightly over-reducing the joint during the initial surgery might actually be protective against the joint subluxing or dislocating again later.
The coracoid ligaments are crucial for the stability of that AC joint. Can those be reconstructed arthroscopically if they're completely torn and maybe retracted?
Yes, there are arthroscopic techniques specifically for reconstructing the coracoid ligaments, which are vital for holding the AC joint stable.
Using what?
These procedures typically involve using donated tissue, an allograft tendon, to create new ligaments. The graft is passed around the coracoid and through tunnels drilled in the clavicle, and then secured with strong fixation devices, all done through small arthroscopic incisions and portals.
When osteoarthritis in the AC joint itself becomes painful, sometimes a small piece of the end of the clavicle is removed at distal clavicle excision. How is that done arthroscopically?
Arthroscopic acromioclavicular joint resection, sometimes called a Mumford procedure arthroscopically, is a common procedure for persistent pain and sometimes instability related to ACJ osteoarthritis or impingement.
What's involved?
Using a small burr through arthroscopic portals, the surgeon removes a small portion, maybe 5 to 10 millimeters, of the very end of the distal clavicle.
Key considerations.
A key consideration for the surgeon is how much bone to remove. Taking too little might not relieve the symptoms, but taking too much could potentially destabilize the joint, especially if the coracoid ligaments aren't perfectly intact.
Risks.
While the arthroscopic approach offers advantages over open surgery, like smaller incisions, surgeons still need to be careful with portal placement to avoid potential complications, like nerve injury. Also, some studies have suggested that in patients who are also undergoing rotator cuff repair and happen to have ACJ arthritis, performing this distal clavicle excision at the same time might not actually provide any additional benefit in terms of outcome.
Mesoacromial. That's when a part of the acromion doesn't fully fuse during development. Sometimes it can cause pain, right? How is that addressed?
Exactly. While often asymptomatic, a mobile mesoacromial fragment, essentially an unfused growth center of the acromion, can sometimes be a source of pain, clicking, and impingement-like symptoms in the shoulder.
How do you confirm it's the cause?
Careful diagnosis is important. This often involves pinpointing tenderness directly over the fragment and sometimes injecting a local anesthetic like lidocaine around the suspected non-union site to see if that temporarily relieves the pain.
And the treatment.
Arthroscopic excision, where the small, separate piece of bone is surgically removed using arthroscopic instruments, is a described alternative to open surgery, either excision or trying to fix it with screws. This minimally invasive approach potentially leads to less post-operative pain and less weakness in the deltoid muscle, which attaches there.
Snapping scapula syndrome, where you feel or hear a grinding or popping sensation as your shoulder blade moves over the ribs that can also be treated arthroscopically. How does that work?
Yes, for snapping scapula syndrome, which is often caused by inflammation of the bursa between the scapula and chest wall, or sometimes a bony prominence on the scapula, both open and arthroscopic treatment options exist. Arthroscopic approaches typically involve either removing the inflamed bursa, a bursectomy, or sometimes partially removing a small corner of the scapula if that's rubbing, a partial scapulectomy.
Advantages of arthroscopy.
Potential advantages over open surgery include quicker recovery and less disruption to the surrounding muscles. Specific portal placements, like the medial and bell portals, are used to access that space between the scapula and the rib cage, the scapulothoracic space.
Any dangers back there?
Yes, surgeons need to be very careful during scapulothoracic arthroscopy to avoid injuring nearby nerves and blood vessels, like the long thoracic nerve or the dorsal scapular nerve and artery.
What about other conditions affecting that scapulothoracic area, like bursitis specifically, or bony growths called osteochondromas?
Scapulothoracic bursitis, just the inflammation of the bursa without necessarily a bony cause, and osteochondromas, which are benign bony growths that can occur on the underside of the scapula or on the ribs, can also be addressed arthroscopically or endoscopically. Imaging, including CT scans and MRI, is important for diagnosis, especially to see the exact location and size of an osteochondroma. Endoscopic resection of osteochondromas in the scapulothoracic space has been shown to be effective, again with potentially smaller incisions and a faster recovery compared to open surgery.
Pectoralis minor syndrome, where the pectoralis minor muscle in the chest becomes tight and compresses nerves or blood vessels beneath it, is a less common condition. Can it be treated arthroscopically?
Hyperactivation or tightness of the pectoralis minor muscle has been proposed as a rare cause of shoulder pain, nerve symptoms down the arm, or even thoracic outlet-like symptoms.
And the fix.
Arthroscopic or endoscopic release of the pectoralis minor tendon from its attachment on the coracoid process can be performed. This is sometimes done in conjunction with other procedures, like the Letarjet procedure where it needs to be released anyway, or specifically for diagnosed pectoralis minor syndrome. It has shown promising results in terms of relieving pain and improving shoulder function in the reported cases, although it's still relatively uncommon. The surgery is typically done with the patient in the beach chair position.
Moving medially to the sternoclavicular joint, where your collarbone meets your breastbone. What role does arthroscopy play in managing disorders there? It seems like a tight space.
It is a tight space. Sternoclavicular or SC joint arthroscopy can be used for diagnosing and sometimes treating conditions like persistent pain, inflammation, or instability in that joint that haven't responded to other treatments.
Contraindications.
Yes, there are certain contraindications that need to be carefully considered before proceeding, like active infection or severe joint destruction. Specific surgical techniques and portal placements are used to access the SC joint, and it requires specialized small instruments.
What about instability?
For SC joint instability, a specific arthroscopic technique has been described that aims to preserve the important fibrocartilaginous disc within the joint while using tendon grafts passed through bone tunnels to stabilize it.
Thoracic outlet syndrome involves compression of nerves and blood vessels in the space between your collarbone and your first rib. Can that be addressed endoscopically too? Seems related to the pec minor issue.
It can be related. Surgical treatment for thoracic outlet syndrome, or TOS, might be considered if non-operative measures fail to provide relief, particularly in cases where there are clear neurological symptoms or vascular compromise.
What's released?
Traditionally, this involved open surgery, often removing the first rib. However, endoscopic techniques have been developed as less invasive alternatives for releasing structures that can cause compression. This might include releasing the scalene muscles in the neck, scalenectomy or scalenotomy, or releasing the pectoralis minor tendon in the chest if those are identified as the compressing structures.
Nerve entrapment around the shoulder itself, like when the suprascapular nerve gets compressed, can cause significant pain and weakness, especially in the rotator cuff muscles it supplies. How is that treated endoscopically?
The suprascapular nerve can get entrapped at two main locations as it travels around the scapula. The sphenoglenoid notch, often by a cyst from the joint, and the suprascapular notch under a ligament.
Diagnosis.
Electrodiagnostic tests like nerve conduction studies and EMG are crucial to help confirm the diagnosis and pinpoint the location of the entrapment.
And the endoscopic treatment.
Endoscopic decompression techniques have been developed to release the pressure on the nerve at these specific locations. This often involves carefully cutting the transverse scapular ligament at the suprascapular notch or decompressing a cyst at the sphenoglenoid notch, all done through small portals using endoscopic visualization.
Medial scapular winging, where your shoulder blade sticks out prominently at the back, especially when pushing, is often due to a problem with the long thoracic nerve, right? Can that be addressed endoscopically?
Yes, the most common etiology for medial scapular winging is indeed palsy or injury to the long thoracic nerve, which supplies the serratus anterior muscle.
And the endoscopic approach.
Endoscopic decompression of the long thoracic nerve along its course, looking for potential points of compression, has been explored and has shown potentially good results in resolving medial scapular winging in some cases. This might be compared to more invasive muscle transfer procedures like pectoralis major transfer, which is sometimes needed if the nerve damage is permanent. The endoscopic approach aims to release any compression on the nerve, allowing the serratus anterior muscle to hopefully recover and function properly again.
Finally, let's touch on fractures around the shoulder. Can arthroscopy assist in their management? It seems counterintuitive for broken bones.
You might think so, but absolutely. Arthroscopy can play a valuable role in managing various shoulder fractures, often in an assisted capacity.
How so? For which fractures?
Well, for distal clavicular fractures, specifically the unstable near type 2 fractures where ligaments are torn, endoscopic or arthroscopic-assisted fixation offers a minimally invasive approach. It allows for visualizing the fracture reduction and placing fixation devices like plates or suture buttons with smaller incisions, potentially leading to lower complication rates compared to open surgery.
What about the humerus itself?
Arthroscopic-assisted techniques are also commonly used for fractures of the greater tuberosity and sometimes the lesser tuberosity. Those are the bumps where the rotator cuff tendons attach. Arthroscopy helps with accurately reducing the fracture fragments, clearing out any blood clot, and then fixing them securely in place using screws or strong suture anchors.
And the main ball and socket part, proximal humeral fractures.
For proximal humeral fractures, involving the top of the upper arm bone near the joint, arthroscopic-assisted reduction and internal fixation, or ARF, is an option in selected cases, usually simpler 2-part or some 3-part fractures. However, very complex fractures with multiple fragments or poor bone quality are generally still better treated with an open approach or even replacement.
Hardware removal.
Arthroscopy can also be helpful later on to assist in the removal of hardware, like screws or plates, after a fracture has healed, especially if the hardware is causing impingement or irritation.
And glenoid fractures, fractures of the socket.
Even some fractures of the glenoid socket, particularly those involving the front rim, bony Bankart lesions, as we discussed earlier, can be managed arthroscopically using suture fixation techniques or sometimes a bony Bankart bridge technique to reconstruct the rim.
Wow, that really was a deep dive. It's incredible, really, to see the sheer number of conditions affecting the shoulder, from instability and cuff tears to nerve entrapments and even fractures that can now be diagnosed and treated using these advanced, minimally invasive arthroscopic and endoscopic techniques.
It is quite remarkable, and as the author of our source material so optimistically pointed out, this field is constantly pushing the boundaries of what's possible. The innovation is just continuous.
Yeah.
We can fully expect even more refined techniques, better implants, and perhaps even more innovative biological solutions to emerge in the years ahead. It's really an evolving field.
It truly makes you appreciate the intricate understanding of anatomy required and the incredible ingenuity that goes into developing these surgical procedures and the instruments needed to perform them through tiny holes.
Absolutely. Precision is key.
So as we wrap things up, here's something for you, the listener, to ponder. Given this rapid pace of advancement in shoulder arthroscopy and endoscopy that we've discussed, what completely new frontiers might be explored in the next decade?
That's a great question.
What conditions that are currently considered irreparable, maybe like severe arthritis in very young people, or massive chronic cuff tears with muscle atrophy, might become treatable through these minimally invasive approaches, perhaps combined with regenerative medicine?
The potential is certainly there. Maybe complex reconstructions we can't even imagine yet.
It's certainly an exciting future to consider for shoulder treatment. Thanks for joining us on The Deep Dive.